My name's Taslima Rashid, and I'm an HIV and sexual health specialist registrar based at Chelsea and Westminster in London. I'll be giving you a talk or a quick run-through in regards to the 1990 fast track and UNAIDS targets and whether or not we've had success in it. These are my disclosures. So in terms of what I'm going to run through today, so I'll just be giving a brief overview about the UNAIDS and Fast Track Cities targets. I'm going to be giving you a very brief overview about the London data that we've acquired and some global data as well. If I have time, I'll do the European data as well, but there's quite a lot. And I'm going to run through some of the reasons why we might not be seeing the whole picture and whether the Fast Track Cities and UNAIDS targets are really a success. So UNAIDS started up the global plan for AIDS care in 2014, looking at getting 90% of all HIV-positive individuals diagnosed, and of those 90% on treatment, and of those 90% virally suppressed. This was a life-saving treatment plan with plans to utilize transmission prevention measures and a basic human right as well. So in regards to the fast track targets from UNAIDS, they wanted by 2020 an ambitious goal to reduce new HIV infections to fewer than 200,000 by 2020, to reduce AIDS-related death to fewer than 500,000 by 2020, and to eliminate HIV-related stigma and discrimination. By 2030, they had also provided much more ambitious goals to reduce the new infections of HIV to zero AIDS-related deaths, and zero discrimination as well. Fast Track Cities was implemented and was a partnership between the City of Paris, UNAIDS and UN Habitat and APACC, with partnerships nationally, regionally, internationally with healthcare providers. And it was a global response in regards to the HIV disease burden in cities mainly, and how large the burden was, that it needed to provide a city-wide and a city-level response to these issues. The numbers were massive, and so the Paris Declaration provided a standpoint to provide a push for cities to provide accelerated care for the AIDS response locally, and also a platform to provide real-time monitoring as well. So the countries achieving the 90-90-90 targets were, as of 2016, there were 7 that achieved the full 90-90-90 targets, including Cambodia, Singapore, and the United Kingdom. And then nearly achieving 90-90-90 targets in 2016 were 11 of the other nations as well. So in terms of the global targets for 90-90-90, we are on track to provide 30 million people with HIV care, which is really exciting, and the projections look really, really reassuring as well. We are also closing in on the fast track targets with 70% of people living with HIV knowing their status, 77% of people living with HIV who are on treatment, and of those people, 82% who are virally suppressed. So in terms of the changes between 2015 and 2016, you can see here that there has been an increase in the implementation and the uptake in terms of HIV diagnosis from 66 to 70%, of people on HIV treatment from 47 to 53%, and people who are virally suppressed from 38 to 44%. So in terms of London and the UK data from 2017, we know now that 38,600 people living with HIV are based in the London area, and our 90-90-90 targets have been reached in London, but also UK-wide, which is really exciting. 95% of people know their HIV diagnosis, and of those 98% are on treatment, and 97% are virally suppressed. In terms of estimated annual infections, we can also see a decline in UK men who have sex with men from 2,700 to 1,200, which is a more than 50% reduction in the estimated annual new infections. And then in terms of incidence from 2015 to 2017, we can also see a 31% reduction from 3,390 to 2,330. So in terms of UK heterosexuals, there has been a decline also, but not to a slightly lesser extent. So as we can see here, these are described as Black African men and women, Black African, Black Caribbean men and women, and white heterosexual men and women. The shortfall lies slightly in the fact that 43% of all diagnoses are still late diagnoses, and of these, 59% are UK heterosexual men, 50% are UK heterosexual women, and 33% are UK MSM. In terms of the London HIV care continuum data, we can see that our projections are good from 2016 to 2017, and there are slightly higher numbers of people living with HIV who are on antiretroviral therapy, and slightly higher numbers of those being virally suppressed as well. In terms of the Public Health England data for new HIV diagnoses, there was an exciting advance back in 2015 to 2016, where we saw that there was a reduction in HIV diagnoses in UK men who have sex with men. And these were mainly based in 5 large London centres. And there has been a year-on-year increase in the median CD4 count at diagnosis over this period of time, which indicates that we are testing people earlier and diagnosing patients earlier as well, which is really, really exciting. In terms of why this is happening, the investigation into the reports of the drop in diagnoses shows that the reason why this is happening is because we have excellent HIV sexual health testing care, and we are testing repeatedly. So quarterly testing of men who have sex with men is crucial to be able to diagnose patients at an earlier stage in their HIV diagnosis. The UK has an open access, high quality and free STI and HIV testing treatment centres across the country, and there have been long histories of health promotion programs with high uptake of condom use, for example. The PROUD trial was also part and parcel of why the downturn occurred, and PrEP, internet provision of PrEP on I Want PrEP Now, for example, which is the website that most MSM use from mid-2016, has really, really affected this change. So I've got to apologise here. Mark really wanted me to put a lot of visuals, and there are quite a lot of these visuals coming up, so bear with. So how do we get people to test? So key populations, for example, men who have sex with men, have real issues going into going into clinics for testing, purely because of the stigma and the discrimination. They don't like going in to do the test. They don't like entering a sexual health clinic because of the connotations it has. And it's really important for us to then do outreach and to reach out to those people in the communities where they are. And so saunas and gyms are large areas of work that we do in terms of outreach programs, but there are other things that we can do as well. So to the right, you can see that this is an HIV testing vending machine, so you can go in for a sauna and you go into the sauna for anonymous sex, but also you can go in for an HIV test as well, which is really important because you can do it there and there. And actually, in this sauna in particular, which is in Brighton, you can see that, you can't actually see that, but there are trained staff and personnel there who will be able to counsel and advise you as well. Most recently, Sexual Health London, which is a partnership with Chelsea and Westminster Hospital, provide HIV testing sampling kits, which can be sent out by post and are small enough to fit through letterboxes, so you don't need to be home when you receive it, but you actually use it by using an app. So an application is downloaded onto your phone and you can use it on your account, and the account then pertains to you getting your results as well. So you do your tests, check your tests, do them at home, send them off, and then you get your results by app as well. And this reduces that whole the HIV testing problem that we have in terms of people coming in. So people don't like coming to see physicians, they don't like coming to see medical professionals because they don't want to disclose sexual activity, the stigma around being around their sexual preference, for example. And so these kits are really, really revolutionising that as well. about other patient groups? So injecting drug users are a notoriously difficult group to access in terms of getting testing and treatment and also retention and care. So in terms of going out, outreach programs are ongoing at the moment, but they're not great in terms of the numbers. So what else can be done? And I'm sorry, there was meant to be an emergency room picture, but it didn't come up. So emergency rooms are places where there is non-discriminatory testing of essentially anything, but everyone goes in there. So heterosexual, cisgender, trans, MSM, you name it, old, young, everyone goes to the emergency room for some reason or another. And the amazing thing about it is that you can test HIV there. So in terms of the UK, Chelsea and Westminster and St Mary's were the first UK London centres in A&E departments to offer routine HIV testing as an opt-out scheme to 16 to 65-year-olds who came in through A&E, regardless of the reason that they came in. So if you have a broken leg, you still get an HIV test. And this was really important because actually it helped us to achieve testing in populations that normally wouldn't come to test in sexual health clinics. And in particular, we've seen a rise in patients who have had HIV positive results in older heterosexual men and women. And this obviously poses a new health outcome in regards to why these patients are being missed. And the late diagnosis difficulty possibly could be attributed to the fact that these people don't come to sexual health clinics to test. So people from all walks of life will always go to A&E to test, and so HIV testing is key there as well. In 2015, we also launched the bloodborne virus screening program, which includes hepatitis B and hepatitis C, together with HIV opt-out testing. So one of the other key aims in terms of HIV prevention strategies is the test and treat, and I can see Neck is smiling. So Dean Street launched an amazing sort of protocol in regards to testing and treating. So the standard would be that you get an HIV diagnosis, and then you would come in 2 weeks later to see the doctor to potentially initiate treatment. But for the 2 weeks that you're waiting, you get things like your blood tests for kidney function, liver function, lipids, glucose, your HLA-B5701, your genotypic resistance test done, wait for the results, then come in for treatment. This obviously posed difficulties in regards to retention and care and coming in for ART treatment start. So at Dean Street, they started by doing HIV testing, and positive patients were almost immediately started on an antiretroviral therapy within 2 days. So basic blood tests would have already come back to make sure that everything was okay, but then they would wait for things like the viral load, the genotypic resistance, and the HLA to come back later. And of 118 patients who had attended for their first doctor appointment, 75% had started antiretroviral therapy at the first appointment, which is phenomenal. So it's really important to show that this is the way to do it. If you want to retain patients in care and if you want to get them virally suppressed quickly, it's more important to treat them as soon as possible. So other HIV combination prevention strategies are community-based, evidence-based, and are very, very achievable. They are based in terms of behavioural, biomedical and structural interventions, and these are, in regards to the UK, HIV counselling and testing, behavioural interventions like motivational interviewing, treatment as prevention, male condoms, female condoms, treatment of STIs, and PEP and PrEP. So in regards to this is another Mark Nelson slide, so I apologise. I should have probably warned you about this before. So these, as you can see, are opportunistic infections. Or indicator infections, not opportunistic infections, sorry. So indicator infections are one of the strategies that were trialled in regards to trying to get patients to be tested more frequently. So our colleagues in dermatology, respiratory, cardiology were all given basic training and understanding of indicator infections. So in dermatology, things like seborrheic dermatitis. In GP, things like basic bacterial lower respiratory tract infections would be a clue to do an HIV test. This sounds like an excellent strategy, train up your colleagues and they will be able to test more frequently. That was the plan. Unfortunately, there are a couple of studies that showed that one of them, during the year preceding the diagnosis, 46.6% of the patients had sought medical advice owing to the presence of clinical indicators that should have led to HIV testing. 46.6%. And then another American study showed that only 9% of patients eligible for screening were screened in the emergency department, serving a population with a seroprevalence of 2%. So that is shocking, but also shows us that this sort of treatment prevention strategy doesn't really work that well. 61% reported not undergoing HIV testing after their last STI diagnosis. So in terms of why this happens and why physicians don't test but also patients don't come to test, it's like a double-edged sword. So clinicians also have issues where they have to improve, and patients also have worries that they have when they come in to test. In terms of clinicians, often we hear over and over again from family physicians, or what we call GPs, and outpatient clinicians, that time is of the essence. We don't have time to test patients for HIV. We don't think we know HIV testing well enough, or we don't know the sort of OIs to look out for, indicator infections to look out for, and so we wouldn't really know when to test. We don't feel like we know enough about HIV to be able to test patients confidently. And what would we do? We won't have time to counsel the patients. Now, we used to do this thing in the UK where we counselled patients on HIV testing, which is complete and utter nonsense. So essentially it was a 15-minute conversation where you would say, do you think you have HIV? Perhaps you do have HIV. Do you have people that can support you in this? And it just took a very, very long time. It prolonged the process, and it caused more anguish and anxiety to the patients than probably was necessary. We need to normalise testing to be able to get past this counselling situation. A lot of people in the HIV, in the A&E departments at Chelsea and Westminster now often just say, in terms of the opt-out testing, that it's almost like just doing a diabetic test. I'm just going to do an HIV test, is that okay with you? And that's all you really need. Unless you're really worried about a patient being HIV positive or they're sick, that's a slightly different situation. But anyone who comes in routinely for an HIV test does not need the rigmarole of going through lots and lots of questions, making them doubt themselves, making them feel a little bit more anxious. It's just not necessary. And then obviously patients are already worried about HIV diagnoses. Do I have HIV? What if I do have HIV? What will I tell my partner? Will I be able to have sex safely? Will I be able to transmit the virus? I don't know. And I don't know because I haven't been given the right information, for example. How will I access healthcare? What if someone sees me? And what if the doctor knows who I am or is a family friend? All of those things are really, really important to bear in mind. So what are the solutions to all of these problems, to barriers to testing? So I liked yesterday, one of the comments from one of the speakers was that we cannot empower people, people empower themselves, and it's absolutely true. You just need to give them the right tools and the information, and they will empower themselves to manage their HIV test. Build capacity to be able to reach out to communities. So outreach clinics, testing out in saunas, testing out in environments where there is sex work, gyms, all of those places. Develop systems that encourage not just the uptake of testing as a one-off, but to retest over and over and over again. The frequency of testing reduces that HIV late diagnosis. Ensure this process is integrated with traditional services and not isolated. You don't want an HIV clinic which is 5 miles down the road from the main hospital, because it further stigmatizes that situation. So one of the pitfalls about these sort of big campaigns that happen, I'm sure globally, for example, for Pride and for National AIDS Day, International AIDS Day, is the HIV testing week or the HIV testing period, HIV testing day, whatever. The pitfall for this is that you think that this is a transient issue. So it's a one point where you can test and that's it, you don't need to test again. This simply isn't the case. And actually we have seen, and I will just show you the next slide now, that Terence Higgins Trust, which is a fantastic charity partner to the British HIV Association, showed a really nice slide where there was the National HIV Testing Week during a period of a week between November and December, and there was a very, very minor spike in the number of HIV tests that were done. And this probably went over, what was that, about a month? Less than a month, I'd say. And then it went back down to normal levels. And actually, if you have targeted marketing, which is persistent and in places which are of high visibility and keeps reiterating the message, you will get a much higher spike, which is what was shown around February time. And obviously, this was a high spike which then went down, but if you persist with this, it probably will just stay sustained and at a high level. So the promotions that they thought were really effective were things like large banners and posters in public transport, trains, trams, buses, anywhere. Sexual health services, obviously, GP clinics, hospital A&E departments, but also geosocial networking apps like Grindr, social media, Facebook, Twitter, and the like. And then normalising testing by using people who communities really trust, go to guidance for, love, an icon, anything. So it could be a pop star, it could be a religious leader like this bishop, could be an imam, but anyone who is very top level but normalises HIV testing, makes it okay to test. They think to themselves, actually, they can test, why can't I test? And that's really, really important. And the moral judgment there is completely, and it's very, very openly saying that this is an HIV status, it's a medical diagnosis, and it's not a moral judgment. That's really, really important to take home. And then in terms of HIV clinics, so I, probably 4 or 5 years ago now, used to work in the West London Centre for Sexual Health, which is an excellent clinic. It has now become 10 Hammersmith Broadway, but where I used to work was in the bowels of the hospital, round the back, underground, windowless. Total and utter atrocity. It was awful. So you would have to go around the back of the hospital, look like you were creeping around doing something dodgy, and then go into the clinic and test. And these banners just show what it was like to test in the early 40s and 50s and 60s as well. And things like, will my parents see if I go to the STD clinic? What will people say? And so making the whole visuospatial awareness of a clinic being around the back of a hospital and being underground is so anxiety-inducing in anyone, regardless of who you are. How can you possibly want to test if you have to go to somewhere that's secluded and dank and horrible? You feel like you're doing something bad to start off with by doing an HIV test, and then you have to go to this place. It's just the worst. So normalising the setting is really important, and so we can see at the top, that is 56 Jean Street, looks like a plush hotel lobby. It's very, very nice. So it makes you feel really open, and it makes you feel like you want to go into a clinic. The bottom picture is 10 Hammersmith Broadway as it is now. I wish I'd done a before picture of West London Centre for Sexual Health, actually. It's open, airy, light, normalises the setting, looks like an open space. There are lots of nice little touches that have been added, like workspaces, plug points, charge a USB, charge a phone, do some work, read some pamphlets, all of that stuff. So it's really important just to normalise the setting as well. And then I think as physicians ourselves, we have to be aware of the times that we live in currently. So before we used to think of the gay scene as pretty dandy, and now it's hypersexualized, geosocial networking apps like we heard about Blue D yesterday in China, and then more commonly in the UK, Grindr. Very, very sexual, much, much easier access to larger numbers of sexual partners, easy access because they're local as well. So we have to bear that in mind. We also have to bear in mind that there are new drug trends. So previously, injecting drug use used to be associated with heroin, homelessness, heterosexual people, and now it's much more. And this is Mark Nelson's slide. I'm really sorry. This is Mark Nelson's slide. In terms of the drug trends that we see now, and we see this very, very commonly in London, and in particular the larger centres, is chemsex. So chemsex is obviously the use of chemicals or drugs for sex to heighten sexual pleasure, to prolong sexual pleasure. And the chemicals that are used are GHB, GBL, methadone, crystal methamphetamine, and the crossover or the danger here is more that the ingesting or the inhaling crosses over into injecting. And terminology has also changed, so it's not injecting drug use anymore. In the MSM community, it's slamming. And so these are the things to be aware of. Heterosexual populations are also using drugs, but to a lesser extent than gay men. So I just wanted to really quickly touch on Europe and the distribution, just because we touched on intravenous drug use. And actually these are some slides pinched from a fantastic data monitoring specialist at the European CDC called Taimur Nouri, so thank you. In terms of the distribution of the routes, we can see that actually heterosexual and intravenous drug use is more common in Eastern Europe and than we thought. And actually, very, very recently, the Russian Federation was able to provide us with data for the European CDC, and that has changed things very significantly in regards to the 1990 targets. One of the things I just wanted to mention very, very quickly was undocumented migrants in Europe. So one of the really interesting points that was brought about by that talk was the fact that there was restricted access to undocumented migrants. There's a large population of migrants who come in from, obviously there have been lots of areas of civil unrest recently in bordering regions, but also the natural migration from rural to urban cities has been ongoing. And one of the really interesting points was that there have been studies to show through modelling data that that a large proportion of migrants who came over to their host nations were not actually HIV positive at the time and actually became HIV positive down the line whilst they're in their host nations. And that's really interesting because it changes the whole concept of what testing is for migrant populations. Most people think it's enough to test at the point of entry when you come into a country, but actually it's much more important to think about a targeted treatment or testing approach to the migrant populations that come through, because actually 63%, it was shown in these 9 European nations, happened to get HIV whilst they were in that country. And so that's really important to understand. HIV education, testing and treatment, testing post-migration as well. So that's all I'm going to say about that. I just thought it was an interesting point. So in terms of global issues, very, very quickly, there is still so much stigma, and it's not helped by governments and legal issues. So criminalisation of sexual preference, drug use, sex work, and HIV as well. So 67 nations currently criminalise same-sex activities, and at least 8 of them hold the death penalty for same-sex relationships. This drives MSM underground. It reduces their availability to access to HIV counselling, care, condoms, lubrication, HIV prevention strategies as well, and it's a really important factor to remember. Drug offences carry unbelievably harsh sentences, in particular the death penalty, in a large proportion of countries. And the most important thing, so Harm Reduction International produce a global report every year, and in 2018 they released this data. And there have been huge advances in regards to reducing the death penalty or executions, mainly in Iran. But unfortunately, with this progression in this implementation, there have been some issues in regards to more hateful rhetoric coming from and implementation of death penalty in new nations like Bangladesh and Sri Lanka, which is really saddening. The highest number of executions to date last year was in Saudi Arabia, and there were 59 executions for drug-related offences. So something to think about in regards to reaching out to your intravenous drug users who might be really scared because they know that it's illegal or it's punishable by death if they want to come forward. Sex workers also, so obviously we know that sex work is illegal in large proportions of countries, but we know that sex workers are 13 times more likely to acquire HIV and 3 times more likely to be beaten up by a client if the nation is criminalised. And so it's really, really important to partner up with local charities and advocacy groups to be able to protect these individuals and to give them all of the HIV prevention care that they need, and as well as their clients. Criminalisation of HIV, I can see that my time is running out, so I'm really not going to go through this, but there are still barriers. The UK, we still have to talk about criminalisation at the very start of our HIV discussion to new HIV positive patients in terms of exposure, transmission, and HIV acquisition. So there's still a long way to go in regards to that. So what can we improve? The 1990 targets are fantastic, and we are doing really, really well in regards to what's being achieved currently. But it almost creates a cloud over what the real issues are. And for me, that's stigma and discrimination. Stigma and discrimination is the most important thing, and everything else pales into comparison if you don't make it priority, and that's the most important thing. Expanded access to testing in routine settings such as GP clinics, emergency departments, outpatient clinics are one way to increase testing. Outreach clinics, again, as I've said, gyms, saunas, STI testing in different areas as well for IV drug users, prisons as well. Better or more standardised reporting of treatment cascades could make it better. We see a lot of data blackout in reporting systems like UNAIDS and fast-track cities as well, because we don't have the data there, so reporting is really, really important. And improvement in partner notification strategies. Making key populations central to outreach and healthcare innovations and strategies as well is crucial. We heard yesterday from Ms. Reena that the Tangerine Clinic in Thailand is key population led, so only trans women lead on healthcare there, which I think is a phenomenal and trailblazing piece of work, and I think it should be one of those things that should be championed and should be brought forward as a model healthcare system for other nations as well. So, as I've said, fantastic, but does cloud the real issue sometimes, I feel. Late diagnosis is still incredibly common, and repeat testing is key, and prevention should be prioritised. But the most important thing is stigma and discrimination. Oh, sorry, thank you. Thank you very much.